disorder that is caused by deficiency in circulating coagulation of clotting factors, that is factor 8 for hemophilia A and factor 9 for hemophilia B. X-linked is a faulty gene on the X chromosome or a change in the gene in the X chromosome. So congenital is an inherited part. It is characterized by spontaneous bleeding into joints, muscles, severe bleeding from trauma, and severe bleeding from trauma. Our patients are male and the women are carriers. Okay, the types of hemophilia. There are 3 types of hemophilia. We have 1, hemophilia A, 2, hemophilia B, also called Christmas disease or royal disease, and acquired hemophilia. There are other types of common bleeding disorders that are always thought to be hemophilia, but are just related or are treated under one roof, that is hemophilia clinic. The common bleeding disorders are von Willebrand's and platelet disorders. So hemophilia, also called factor 8 deficient or classic hemophilia, it is a genetic disorder caused by a missing or defective factor, factor 8, which is a clotting protein that is required by every human being. In our setups, we treat factor 8 deficient with cryoprecipitate where we do not have factor 8. And we have the gene mutations that cause factor 8 deficient are cross gene rearrangements, which is almost 100% positive agent of the gene mutations in hemophilia A patients. We have insertions, deletions, or inversions of the genetic sequence where the codons are reversed. During the coding of the gene in a human system, we find that the codons might either be reversed, deleted, or inserted. So that is why you find that there is we find this in hemophilia A. There is also missense, or where we find that there is replacement of a codon on the strand of the gene. We also have stop or nonsense mutations, where we have this premature coding. Either they stop when there is that coding or reading of the gene, it reaches a place where the codon stops, or it stops prematurely. Okay, hemophilia B, also called factor 8 deficient or Christmas disease, or factor 9 deficient, or Christmas disease or royal disease. It's called Christmas disease because it was first diagnosed in 1952 in a patient who was 4 years old called Stephen Christmas. That is why it was called Christmas. Or it is called royal disease because it was first diagnosed in a royal family where he had 4 children, that 2 died and 2 were carried on the disease in the family. And we had three daughters who were the carriers of the gene. They kept on. They had each daughter had a son who had hemophilia. It is passed on from parents to children. In times when there is no factor 9, usually in facilities where there is no factor 9, we have a fresh frozen plasma that is given to the patient which has a high content of factor 9. Factor 9 gene mutations. We have a point mutation where the
Yeah, from square zero. We are so sorry for the hitches in sound. Our technical team is trying to sort out, but we hope we'll keep on. We'll go on smoothly now. Okay, what is hemophilia? Hemophilia is an X-linked congenital bleeding disorder that is caused by deficiency in circulating, coagulation, or clotting factors. That is factor 8 for hemophilia A and factor 9 for hemophilia B. X-linked means there's a fault on gene on X chromosome, on the gene of X chromosome, or there's gene changes. Congenital means it's inherited. That's hemophilia is got from a parent down to the children. It's characterized by spontaneous bleeding in the joints, in muscles, and severe bleeding from trauma. Our patients are majorly male, and the women are carriers of the disease, which means they pass it to their children. Types of hemophilia. There are 3 types of hemophilia, but we have other common bleeding disorders that are always confused for hemophilia. But the main types are hemophilia A, hemophilia B, which is also called Christmas disease or royal disease. It is Christmas disease because it was first diagnosed in 1952 from a 4-year-old called Stephen Christmas. And it's called a royal disease because it was first diagnosed in a royal family, Queen Victoria's family. And Victoria gave birth to 2 sons who were hemophilic. One died and one survived, and had two ladies who were 2 daughters who were carriers who gave birth to hemophilic sons. We have acquired hemophilia, which is a patient meets from the course of either a diagnosis or treatment in her line of disease. So it just comes whichever age. It does not. It is not inherited. Other common bleeding disorders that people confuse with as hemophilia are von Willebrand's disease, that is VWD, and other platelet disorders. Okay, hemophilia A is called factor 8 deficient or classic hemophilia. It's a genetic disorder that is caused by a missing or a defective factor 8, that is a clotting protein in the system of a human being. In our setup or in our periphery facilities, if there are no factor to replace in a patient, the cryoprecipitate is used because it has high content of factor 8. So there are so many gene mutations that happen in hemophilia, and some of these are that are majorly known are 4. One is cross gene rearrangements. You find that cross gene rearrangement takes up to 50% of patients with severe hemophilia, and you find that during the coding of the gene, you find that there's either insertion or deletion or inversion of the gene sequence to find that the patient ends up having hemophilia. There is also missense or single gene codons that substations that result in amino acids being replaced on the gene codon. Also, there is the 4th is stop or nonsense mutations. This stop mutation is where the codon is stopped prematurely before the whole gene is read or transcripted on the gene of a person. Hemophilia B. It's also called a factor 9 deficient or Christmas or royal disease, just as I explained why it's called Christmas and royal. It's a genetic disorder caused by missing or defective factor 9, that is a protein in the clotting system. It is passed down from parents to children, and it sometimes, when there is no factor 9 in a facility, fresh frozen plasma is used to replace the factor 8 content. So fresh frozen FFPs has high content of factor 9. We have a few gene gene mutations in hemophilia Bs, and these are point mutation, where you have a single nucleotide being replaced by another nucleotide that is not supposed to be read. So you find that the patient ends up having hemophilia. We have stop or nonsense, which you have seen in factor 8 deficient. Also, there's an introduction of a premature or stop codon during the transcription of a gene. Then there is complex rearrangements, just as we saw in factor 8 gene mutation. But you find that there are few as compared to factor 8. In factor 9, we have few patients having this. And hemophilia B is less common. That is accounts to our patients, hemophilia patients, we have 20 to 25% in our registry having hemophilia B as compared to hemophilia A. So the third type of hemophilia is acquired hemophilia, which is a rare autoimmune disorder that is characterized by bleeding that occurs in patients with personal or family history that is negative. And someone cannot actually say where the hemophilia came from in their lineage. It is an autoimmune disorder that occurs when the body's immune system is mistakenly attacked by healthy cells or tissues. You find that it may come in as a pre-existing underlying autoimmune disease, malignancy, or infections like HIV, hepatitis B, or hepatitis C. Okay, levels of hemophilia. They have clinical manifestations. For you to say this is a severe bleeder or this is a mild bleeder or a moderate bleeder, you have to know the levels of hemophilia. It is actually classified in 3 for you to know that this is a patient who is a severe bleeder or a mild bleeder. So clinical manifestations of bleeding in hemophiliacs depends on the severity of that disease. Severity of the disease also varies from mild to severe according to the functional plasma level that are of the clotting factors that are in the circulation. So the severity of the bleeding is inversely proportional to the levels of factor 8 and factor 9 circulating in a person's blood. Also, severity of the condition in any particular family is usually the same. It never changes. A person does not run from severe to moderate patient. The patient will remain severe the whole of his or her life. Okay, this severity, just as I've said, is we have severe, moderate, and mild. In severe cases, the functional plasma levels are below 1% of normal, and the patient suffer from spontaneous bleeding even in the absence of trauma. Or when a person is just rested and sitting, the person starts bleeding from the joints, from the muscles, anywhere, and you find that the patient will start feeling the auras of bleeding. Factor 8 and factor 9 replacement is needed several times in a month for a severe bleeder. And you find that it has to be, it is done severally every now and then. The patient comes in with bleeding. The patient comes in anytime because of the severity of the bleeding. The tendencies appear early in childhood and sometimes early in neonatal life of a patient. And severe patients, 15 to 20% develop antibodies because of frequent exposures to factor or replacement agents. Okay, we go to moderate. Moderate is between the person has a 1 to 5% clotting factors circulating in the person's system, and there's less frequent bleeding episodes as compared to severe. Bleeding usually follows traumatic surgery or other traumatic events like dental works or falls. That is when you find that there is bleeding. In mild you have a person has at least more of the clotting factor, that is 6 to 25% factors circulating in blood, and find that bleeding happens occasionally. This person does not come in on and off in the clinic, having bleeds from the joints, from the muscles, and it's usually after a severe trauma or surgical experience. So you find that the person will come in only when there is trauma or there's something that happened to warrant this person to bleed, as compared to severe bleeders. Usually the normal ranges are between 50 to 150% in a normal human being, but in patients, sometimes in carriers, we find that carriers have between 40 to 60% of the clotting factor circulating in the blood. Okay, the severity table is here, and you find that the normal factor level circulating in a normal human being is between 50 and 150%. And for the severe cases, severe hemophiliacs, you find that they have very low clotting. In fact, some of them come with 0.8%, 0.3%, and they need factor replacement for them to go back to their normal function. So they have 0 to 1%. And majorly, we have so many of these patients in the clinic. They just bleed spontaneously. We have moderate hemophiliacs. The moderate bleeders, they have at least 1 to 5% of clotting factor circulating in the blood, and we have at least 15% of this in our registry. So they only bleed when there is trauma, mild trauma or mild surgery, or some surgical procedures that are carried on them. When they bleed so much, when a person realizes this patient is hemophilic. We have in mild hemophilics, we have at least 5 to 25%, which means these ones have at least some clotting factors that can protect them from traumatic events that they might get in their way of living. And you find that at least we have 25% of these patients in our registry, and it comes as a significant or major trauma. It just doesn't come. Epidemiology of hemophilia. The disease affects 1 out of every 10,000 persons in a population. And globally, the population of 7.7 billion, we have 7.7 billion. There is an estimate of 770,000 people living with hemophilia globally. And hemophilia A is common. In our registry, almost 80% of our patients are hemophilia A, 15 to 20%, that is 20 to 25% are hemophilia Bs. We do not have so many of patients with hemophilia B. And in Africa, there is 637 patients, 6,387 patients identified out of 83,000 living people in Kenya, which is only 8%. So you can imagine where we are. We still have a wide gap to get these hemophilia patients. It's because most of our setting, people think it is witchcraft. So a person will just bleed to death because they are not believing what is happening, or they think it is not something that is serious to see this patient bleeding, or they think it's normal. In Kenya, we have 650 patients, but our registry is growing. I think we are up to now, we have 700 and above living with hemophilia, identified out of the expected 5,000. So we have 12% identification rate, which means we have also a very wide gap to get all these patients treated. Or people are just dying in the village, others are coming and going home thinking it is something that is not very serious, or it is witchcraft. Okay, genetics. Hemophilia is usually inherited from an X chromosome, that is X chromosome from the father or X chromosome from the mother. Majorly in hemophilia A, hemophilia B gene mutations, just as we tackled earlier. 70% of all cases result from spontaneous genetic variants. And so hemophilia usually affects only males. Most of our patients are males. We only have one patient who is female that came as a result of acquired hemophilia. So almost all our patients are male who inherited an infected maternal X chromosome. Females with hemophilia are rare, but there are some cases where we'll see from the genes where we will end up having a a couple or a family having a lady with hemophilia, but it is very rare. We have not gotten any in the clinic as per now, except the acquired one. Both X chromosomes are affected in where we have a female having hemophilia. We'll find that both X chromosomes are from two affected. Yeah, father and mother having affected X chromosomes. A female with one X chromosome is called a carrier or an obligate carrier. The carriers are usually asymptomatic, or they may not get the signs and symptoms, or are rarely affected, not unless they go through very traumatic events like giving birth. Is when you will see this mother either bleeding heavily, or bleeding, or during periods you find that the mother bleeds heavily. Okay, this is a genetic tree of a mother or a lady who is a carrier and getting married to a man who does not have hemophilia, or who is not a carrier. So you find that the lady will pass the affected X chromosome to the son, and to one of the son. Actually, this lady who is a carrier has 50 chances of getting hemophilia boys, and 50 chances of having a lady who is a carrier. So you find that this lady will have one chance of getting a normal son, another chance of having a normal daughter, and a hemophilic son and a carrier daughter, just as you can see from the table. And this tree will give this is a father who has hemophilia getting married to a lady who is not hemophilic or has no hemophilic trait. So find this father. See, let's see what happens. This father has all the sons. The father donates the Y chromosome to the sons. So we find that all the sons of this man are normal human beings, because they are getting X chromosome, they are getting Y chromosome from the father, and the father gives X chromosome to the daughters. So you find that all the daughters of this man are carriers of the hemophilia gene. So all daughters of a hemophilic man are carriers of the hemophilia gene, while sons will come out to be normal. Okay, father has hemophilia and mother is a carrier. I think we have not gotten this so far in our setting, and in our country, not unless we will. But anyway, you can still get it somewhere along the way, and because our patients interact so much, you can get them. They can get themselves in this scenario. But we hope and pray that it will not get there actually. So this is a father who is hemophilic and a mother who is a carrier of the hemophilia gene. So a carrier lady and a hemophilic man. What is the outcome? You find that there is 50% chance of a son with hemophilia and a son who is normal. So all sons of this man will be normal, except where a mother is donating the affected X chromosome. So if a mother donates the normal X and a father donates the normal Y, you find that one of the sons will be normal. But where a father donates the normal Y and the mother donates the affected X, you find that one of the sons will be hemophilic. So when you go to the daughters, you find that the mother donates the affected X and the father donates the affected X. Find that there is one lady who is, or one daughter who is hemophilic. And where a father donates an affected X and the mother donates a normal X, you find that that lady will be a carrier. So this family, actually, you can see it's 100% hemophilic, except one son who will get out normal. So we have one lady carrier, one lady hemophilic, one man hemophilic, or one son hemophilic, and one son who is normal. So this is actually a concussion of this hemophilic family. You find that there is a hemophilic lady, hemophilic man. So actually this family is it's a concussion of So this is what you expect from people who are hemophilic and carriers marrying one another. Okay, thank you. That is the end of my presentation. I now want to welcome Dr. Victoria Githinji to come and continue with her presentation. And we will take our questions after. Thank you.
Good afternoon, listeners. Thank you so much for joining us for this afternoon session. My name is Dr. Githinji. I'm a medical officer. I work at the Hemophilia Comprehensive Care Clinic at the Kenyatta National Hospital. Today, I'm going to present to you the types of hemophilia, the manifestations, and the treatment. So as we all know that the most affected part of hemophilias is the blood, and it works, it affects the coagulation cascade. And as our sister Nguche has described, we have both factor 9 and factor 8 deficiency, that is hemophilia A for factor 8 deficiency and hemophilia B for factor 9 deficiency. So on the coagulation cascade, where you see the factor 9, that is hemophilia B, and where you see factor 8, that is hemophilia A deficiency. So the clotting in hemophilia is distorted, and what we normally see in the physiology is when you have a vessel injury, there will be spasms to that blood vessels, and the platelets should adhere at the injury site, form an aggregation and form a plug. But in hemophilia, there is a breakdown where there is the deficiency of the clotting factor. Let's say it's the factor 9 or the factor 8, then the bleeding persists instead of a plug forming. And that is how the bleeding comes along. So what are the clinical features for our patients? So the characteristic phenotype in hemophilia is a bleeding tendencies. Most of them are going to bleed either obviously, like an external bleed, maybe from a cut or a traumatic injury, or internally, maybe in a joint or in the abdomen or in the head. While the history of bleeding is usually a lifelong, some children with severe hemophilia may not have bleeding symptoms until later when they start walking or running. And of note is at this point is when we normally start diagnosing most of the patients, because they're more mobile and they're discovering their environment. And when they start getting injuries, this is when the parents tend to note something is different from the other children about this particular bleeder, and they present them at our clinic. So bleeding symptoms depend on the disease severity. As mentioned before, we said severe is less than 1%, moderate is 1 to 5%, and mild is 5 to 40%. Whereas the normal levels we have mentioned is 50 to 150 international units. So what are the types of bleeding in a hemophilia patient? So we normally categorize them as minor bleeds and major bleeds. So I will start with the major bleeds. These bleeds are life-threatening most of the time, may cause deformities, or may be fatal. Body areas associated with major bleeds include the central nervous system, the gastrointestinal tract, the neck, the throat, the hip or the iliopsoas muscle, the advanced joint or muscle, or you can also find a big muscle chunk that is involved, and this can lead to compartment syndrome, for example, in the thigh, in the calf area, in the forearm, and this is in severe injury most of the time. Minor bleeds, these bleeds do not impose an immediate danger to our patient. However, if they're prolonged, they may cause complications and therefore should be treated early. They include joints, mostly. These are actually one of the commonest sites of bleeding. Joints, so you get early hemathroses, muscles or soft tissues, the oral cavity, nose bleeding, painless hematurias. So the other clinical features, for example, so let's start with the most common location for bleeding for our patients, which is the joints. So joint bleeds, soft tissues, muscles, ligaments, tendons, these are all involved because the joint is encompassed with all this. So the patient may come to you and report of tingling sensation or an aura. We report it as an aura. They may have a feeling for early joint bleeds. And normally a patient can come to you and tell you they have been maybe involved in heavy duties or activities, maybe at school, at work, and they're having tingling sensations or heaviness in the joint. Some may have pain, others may have persisted for a day or two. So there's warmth and tenderness, there's swelling, there's a limited range of movement for this particular joint. There's limited use of that affected area or the whole limb per se, limping or inability to use that affected limb, stiffness of that joint, and muscle tightness. Like shown in the picture in this slide, you can see this patient has an acute joint bleed and it has persisted for, this one looks like 2 or 3 days old, and it starts as a tingling sensation. So when you ask the patient, how did this start? They'll tell you, I started feeling a discomfort in my joint. There was pain, but if it's not treated immediately, this is how it looks after 2 to 3 days. So with joint bleeds, these ones we call hemathrosis. This is the most common presentation in our outpatient clinic. So after one or several hemathroses with synovitis, the joint may become a targeted or recurrent bleed, or for recurrent bleeding and damage. So these joints, we call them target joints. You find that in a patient, a hemophilia patient, there's one joint that persistently bleeds. We treat it, but after some activity, they come back again with the same joint bleeding. Maybe it's the right knee and it's always bleeding. So these joints, we call them target joints. Muscle bleeds, these ones always need prompt treatment because of the risk of compartment syndrome, which may cause neurovascular damage. We've seen such cases where the patient stayed at home because they did not think maybe an impact or a fall was that bad until a day or two when they come and the whole muscle compartment is swollen, it's tight, it's painful. They cannot ambulate using that particular leg, for example, and they're in excruciating pain. And most of the times they even present with paresthesia or numbness to the lower part of the swelling. And normally what we try to achieve is hemostasis as quick as possible to avoid compartment syndrome. So one of the other major bleeding sites for our patients is the head injury, which is the central nervous system. This is always a medical emergency, can occur with or without recognizable trauma, especially in children. Like Sister Anguche mentioned before, the severe bleeders, these are the ones who have less than 1% factor in circulation, mostly present with this picture. Patients with suspected head injury must be given factor infusions as soon as possible. So if you're suspecting a patient has a head injury and is a non-hemophiliac or just confirms to you that they are a hemophiliac, always aim to treat before you do any imaging. You aim to give factor at 100% correction before you do any imaging, anything else, just to try and lower the complications. So what are the signs and symptoms of head injury? The patient may come to you with headache, vomiting, irritability, convulsions. There's lethargy or drowsiness, especially for the young children who are learning how to walk. The mother can come to you and complain that the baby is unusually sleepy or unusually drowsy, despite them being unlike the other days where they're active and, you know, jumpy and jolly, so they're unusually sleepy. So there's some have visual disturbance, there's focal neurological deficits, for example, weakness, even like a whole right-sided weakness or left-sided can be indicative of head injury. Loss of consciousness, some actually come in coma at the ANE. So that means the bleed has prolonged and it's quite extensive. Some also have paralysis. The other major bleeding site is the GIT, the gastrointestinal system. This is also a medical emergency. It could be blood, it could be, so the patient could present as fresh or coffee ground vomiting with fresh blood or coffee ground vomiting. They could also report to that they have dark or tarry stools. They could be having acute abdominal pain, including the retroperitoneal area. The hemorrhage can present with abdominal pain and distension and can be mistaken for a number of infectious or surgical conditions. So for example, the patients with GI bleeding, we always want to be thorough and with our investigations, always make sure you ask the patients about their diagnosis. Like CNS, give factor before any imaging, then you proceed for your imaging. Avoid tapping. For example, if there's some form of abdominal swelling or distension, because this may not be ascites or it may worsen the condition. So you give factor at 100% and then you proceed to do your imaging and other supportive care. So the other types of bleeding are mucosal bleeds, oral bleeds. For example, dental or gum bleeding. A child can come with a tongue laceration, maybe they fell and bit their tongue, and this bleeding is not ceasing. Other presentations are epistaxis. Patients could be having persistent nosebleeds, especially when it's flu season, we get a lot of this, and parents come in with children who have those bled maybe overnight. So that is also an area to watch out for. The genitourinary system, these ones are normally spontaneous, painless, persistent, or can also be recurrent. So when you have a genitourinary bleed, the one thing to always avoid is tranexamic acid, which will lead to formation of clots, and it's going to cause obstruction in the urinary tract. So when you suspect there's a urinary bleed or there's an injury to the bladder, kindly avoid tranexamic acid. Just give your factor or give your factor concentrates or other measures, but avoid the tranexamic acid. Post-circumcision bleeds, these are other things. For example, like the right bottom photo, as you can see, that was a complicated unsafe circumcision in a hemophilia patient who was probably circumcised during, because in our setup, we know this is a rite of passage, but if the patients have not been screened and then you detect a patient who's bleeding profusely without stopping, that is a patient for quick screening and further management in a setup where he can be safely taken care of and the bleeding can be controlled. So post-circumcision bleeds are something to really watch out for, especially in this season. Thank you. To the next presentation. My other presentation is on the treatment of, how we manage the patients who have, how we manage patients with hemophilia. Thank you. So for patients with the different types of bleeds, whether major, whether minor, we our goal is to achieve hemostasis. And by this, we mean replacing the deficient factor. Besides the other measures we take to stabilize our patients in case they are in a compromising state, for example, for the patients with head bleeds or abdominal bleeds, and maybe they're anemic, but anemic or unconscious, the first thing we aim to do is replace the absent factors as we manage the other side effects of bleeding. So clotting factors are given in international units, and they're calculated in international units per kg body weight. So the treatment of different bleeding episodes, for the minor bleeding episodes, for example, an early joint bleed, soft tissue, mucosal bleeds, nose and gum bleedings that does not respond to local measures. For example, mucosal, sometimes we tend to give tranexamic acid alone and they respond. We can do correction of the factor, which is like for the minor bleeds, we aim to at least achieve 40% correction. That is circulating factor 8 or factor 9 is needed to stop that bleeding. So for major bleeds, the rule is always aim to get 80 to 100% correction in circulation for this patient to stop the bleeds, because major bleeds are always life-threatening and can be fatal. So clotting factors, dose calculation. So how do we calculate? How do you know how much to give a certain patient who has presented to you? So for factor 8, or that is hemophilia A patients, the rationale is 1 international unit per kg, factor 8 raises the plasma level by 2%. So for a minor dose, like a mucosal bleed or a gum bleed, you can give at 20 international units per kg. A major dose you can give at 40 international units per kg, and this will raise by 2%. So for a minor bleed, when you raise by 20 international units per kg, you will achieve a correction of about half. While for a major bleed, you will get up to 100% or correction. The half-life of factor 8 is usually 12 hours. Although we have now reagents that are longer than this, but for most of the factor 8 concentrates are 12 hours. 1 international unit per kg of factor 9 raises the plasma level by 1%. So a minor dose, for example, to achieve just a minor correction of a mucosal bleed, you want to give about 40 international units per kg, which will give you around 40 to 50%. Whereas a major bleed, you'll give at 80 international 80 international units per kg, and will give you about 80 to 100% correction. Half-life of factor 9 is 18 to 24 hours. So like we said, the minor bleeding episodes are when a patient presents with early joint bleeds, soft tissue or muscle bleeds, nose or gum bleeds that do not respond to local measures, and the treatment we have said we aim is at about 40% correction. So for factor 8, we'll give 20 international units, which will replace at 2%. And for factor 9, 40 international units, which will be 1%. So the ratio for factor 8 is 1 to 2, and the one for factor 9 is 1 to 1. Major bleeding disorders or episodes, major bleeding episodes, advanced soft tissue and muscle bleeds, head and neck injuries, GI bleeds, advanced joint bleeds. The treatment here is always 80 to 100% correction. You want to really elevate the factor concentrates. And so for factor 8, you'll give at 40 international units per kg, whereas for factor 9, you'll give at 80 international units per kilogram. So blood products used to increase the circulating level of factor 8 or factor 9, you can start with whole blood. in the event that you're in a setup where you do not have this factor concentrate, you can give the fresh frozen plasma and cryoprecipitate. This is only used for factor 8 deficient patients, hemophilia A. So disadvantages of blood products are as simple as possibility of volume overload. You may get allergic reactions or risk of virus transmissions, just like any other blood transfusion. These are the things to look out for and do your proper screening. For factor replacement, plasma-derived concentrate, I don't think we use that anymore. We use recombinant concentrates, which are very expensive and scarce, but that is what we have at the moment. So thank you very much. As we go on to treat for a bleed using the other products. So these are samples of blood products that we normally give. In our setup, I know most setups that have good blood transfusion units, you can get fresh frozen plasma separated. This is separated from blood and frozen. It contains factor 9. So this is an option when you want to control bleeding in a bleeder who is undiagnosed. Cryoprecipitate, this one you need to know that the patient is hemophilia A because it is concentrated with factor 8 only. So factor concentrate, this is plasma dried down to powder and diluted in sterile water and contains factor 8 or factor 9. These ones are available. You can also replace with whole blood. And it's not a treatment for bleeding episodes, but may be needed for severe blood loss and related to the bleeding. So that's an example of treatment options, that is whole blood. Next slide, please. This is fresh frozen plasma separated from blood and frozen. This one contains both factor 8 and factor 9. So in the event that the patient is undiagnosed, always go for fresh frozen plasma. And it contains all other procoagulants and anticoagulants. Cryoprecipitate, again, I repeat, its plasma is separated further and contains factor 8, but not factor 9. Sometimes we recommend the use of desmopressin, but we have not used it in our setup. It causes the release of factor 8 and von Willebrand factor from the endothelial stores. It's aimed to achieve an increase by 2 to 3 in the baseline levels. The advantages is avoids blood component exposure. It's less costly than factor concentrates. And the route of administration for desmopressin is either IV or sub-Q. You can also find it in intranasal forms. That's an example of DDAVP. The other commonly available products are the antifibrinolytics. These ones protect against fibrinolysis in inhibiting conversion of plasminogen to plasmin. These ones we have found to be very useful, especially in oral mucosal bleeds, also useful in other types of, oral and mucosal bleeds. So the dosage of tranexamic acid is normally 25 milligrams per kg, 8 hourly. The other option is aminocaproic acid, which is 100 milligrams per kg every 6 hours or 3 milligrams every 6 hours for adults. But what is most commonly available is the tranexamic acid. So how do we mix these factor concentrates? There's a diluent, there's a mixing device, and there's the lyophilized powder. I believe some of our patients have the know-how of how to mix these medications because we teach them at the center. but it comes in a diluent, a mixing device, and the powder itself. So once factor is mixed, inspect to be sure all powder is dissolved. Specific mixing instructions are listed in the package insert. So it doesn't matter the location of the clinician. If you follow the insert, you'll be able to mix the factor concentrates and administer correctly, mostly IV. Always give the contents of the whole vial, even if it is larger than the calculated dose. Why? Because we avoid the wastage, and most of the times we only treat our patients on demand when they have an active bleed. So we tend to minimize wastage, and we round up the dosage to the nearest dose of the vials provided. So these are examples of some of the factor concentrates that have been there. There's so many more in the market, but this is just how they looked. There's adapters, there's water for injections, already provided. Some come with the water for injections and the adapters. So the mixing is also elaborated in the inserts that you find in the boxes. That is how a demonstration of how to mix the diluent and the lyophilized powder. In between is the adapter. So treatment options, what are the treatment options for factor H deficiency? You have whole blood transfusion, FFP, cryoprecipitate, desmopressin, plasma factor 8 concentrates, recombinant factor 8 concentrates, and your antifibrinolytics. Treatment options for factor 9, we have whole blood transfusion, we have fresh frozen plasma, plasma factor 9 concentrates, recombinant factor 9 concentrates, and your antifibrinolytics. So what is contained in the fresh frozen plasma? So 1 unit bag of plasma is about 200 to 250 ml. So 1 ml plasma contains at least 1 international unit of factor 8 and 1 international unit of factor 9. Therefore, 1 unit bag of plasma contains the same range, 200 to 250 IU of factor 8, and the same for factor 9. So plasma also contains all other clotting factors, factor 7, 10, and fibrinogen. And this especially is useful because of late we are also diagnosing rare bleeders who do not necessarily have factor 8 deficiency or factor 9 deficiency, but they have the other deficiency, maybe a factor 7 or a factor 10. So when you give your FFP, you still achieve clotting. So as the practice is for any patient who's going to receive any blood product, you have to do your ABO compatibility. You need to prepare the patient and give it as soon as it's stored, check for unusual reactions to the blood, infuse it over about an hour and monitor closely for the vital signs and for any infusion reactions. So cryoprecipitate, again, is a component prepared by throwing 1 unit of fresh frozen plasma and removing the cryosuppernant. So 1 unit is a bag of cryoprecipitate obtained from 1 donor. It contains an average of 100 international units of factor 8. It does not contain factor 9. So like I said, this is a product you use when you know the diagnosis is hemophilia A. Just like fresh frozen plasma, you have to go through the normal routines, and as you infuse, monitor for any reactions. So summary for factor replacement, that is just a table to show you what you get in fresh frozen plasma and in cryo. So this will this is a table that guides us to know in what event to use what product. But when you're unsure, always go for fresh frozen plasma because it has most of the components, most of the clotting factors. And so you are sure to at least stabilize the patient before you get any factor concentrates. Dosing recommendations for factor replacement therapy. So you always need to classify the type of bleeding you have. What type? Is it a joint, a muscle? Is it a retroperitoneal bleed? Is it soft tissue? Is it a major bleed or a minor bleed? So the dosing goes with the classification, the type of hemorrhage, and the location. Is it a head bleed? Is it an abdominal bleed? Or is it just epistaxis that might not need as much factor unless it's a bleed that is life-threatening? So you dose according to your judgment. The lower the dose, the less the bleed. The higher the dose, the more life-threatening the bleed. Like we said, the dose calculation, I think this is a repetition. Sorry for that. This is a case example for a minor bleed episode of a 30 kg patient with factor 9 deficiency, where you have 40 international units per kg raises by the level of 40%. We said factor 9 replaces 1 to 1. That's the ratio. You will have to give around 1,200 mils of plasma, which is around 45 units, pints of whole blood, and 5 units of fresh frozen plasma. So depending on your setting, you'll make a judgment of how fast and how well you will control a bleed. This is also a case example of a 30 kg patient with factor 8 deficiency, who you want to replace 40 international units per kg. It will raise it by 80%. You will have to give 1,200 mils of plasma, or 45 units of whole blood, or 5 units of fresh frozen plasma. Or in the case of factor 8, you said you can also give cryoprecipitate. This will be 12 bags. So this is an example of a major bleed, but same applies to this patient. The higher the dose, the higher the correction percentage in the system. So use of blood products, the patient has to be admitted, of course. Treatment limitations, or you have to look at the volume of fluid tolerated, and any other comorbidities. Of course, transfusions are given over a period of hours, and the number of units desired may not be available. So of course, in our setup, you work with what is available as you try to get the factor concentrates as quickly as possible to the bleeding patient. You can use fresh frozen plasma if you're not sure whether the patient has factor 8 or 9 deficiency. So as always, our slogan is do what you can. When a patient is admitted, find out what products are available, give the products available, calculate the predicted factor level after infusion, think about factor half-life, and estimate the trough levels 12 to 24 hours after initial infusion. Then also match your clinical expectations with the amount of factor received by the patient. Some respond quite well, others may take a bit longer, also depending on the severity of the bleed. For example, if you only have fresh frozen plasma to get the factor level up to 10%, but at least the patient may be stable until maybe further management or a referral. So degree of pain relief can help you determine clinically that the patient is responding. For some patients, even with a major joint bleed after fresh frozen plasma infusions, the pain tends to reduce, or the intramuscular bleed tends to reduce, and you know that you're actually achieving some hemostasis. The hemoglobin level can be a very useful coagulation test that tells if your bleeding has stopped. So like for the different bleeds, our aim is to detect the early symptoms and treat as quickly as possible. Infuse the dose that is recommended. Some will present with extreme pain, swelling, heat, and immobility in advanced bleeds, and requires a major dose, quote unquote. Muscle and soft tissue bleeding, any muscle group but common sites, upper arm, forearm, thigh, calf. These are very common bleeding sites. Toddlers frequently have buttocks and groins, so do not avoid examining these patients. They come with groin bleeds. Patients with low abdominal or groin pain area likely have an iliopsoas bleed. This is a major bleed. It's a retroperitoneal bleed, and this one you want to treat at 80 to 100% factor replacement. So what are the consequences of muscle bleeds? You can have extensive blood loss in large muscle groups, pressure of nerves and vessels, which can lead to compartment syndromes. Normally, you can consult your nearest hematologist before thinking surgery. Always consult. So most muscle bleeds respond well to medical management. So treatment and follow-up, minor dose of factor treatment follow-up. So, okay, for major or minor, we have follow-up. We normally do follow-up. And we tend to encourage our patients to come for at least one more visit after their scheduled treatment program is over, so that we can follow up and ensure that we have achieved complete healing, the bleeding has stopped, the swelling has stopped, and then we can start rehabilitation, for example, for joints that have undergone hemarthrosis. The other kind of treatment we encourage our patients while at home is to rest the limbs, for example, place ice packs, compress where necessary with soft compresses, of course, and keep the limbs elevated. This really helps, especially with joint bleeds, hemarthrosis. So for major bleeds, you do major dose with repeated infusions, for example, the large abdominal muscle groups, the iliopsoas, and you normally achieve hemostasis and complete recovery. For the soft tissue and superficial bleeds, the patient may even come with hematomas, maybe from a tooth extraction or a gum bleed. Normally, they can resolve by themselves after forming a hematoma, but we always like to support them with antifibrinolytics like tranexamic acid, or even use the factor concentrates. Genitourinary and GI bleeding, patients who present with abdominal or flank pains, melena, hematemesis, or frank hematuria. These patients you want to always correct with 100% factor concentrates. And most of the times we admit for close monitoring until full recovery. Hematuria is another very common complaint, especially in our school-going and adult patients. It's usually painless, but they can report clots or frank blood. So it could be either because of trauma, kidney stones, or it could be just spontaneous. So we normally encourage bed rest, increased fluid intake. You can give something for the inflammations, but remember the contraindication in this case is the antifibrinolytics. We do not want to give tranexamic acid and worsen the situation because it causes clots. Mucous membrane bleeding, immediate treatment needed. Of course, if it's profuse or prolonged, or it's an injury to the mouth or the tongue or the nose, it can even cause airway obstruction. So sometimes you assess your patient and you determine, does this patient need a quick admission and advanced support? So these are the things you always need to look at. If a patient has been involved in a road traffic accident and they report to you that they are hemophilic, you always want to assess the patient and make sure that you do the best for them as you look for the factor concentrates or the blood products. So causes for bleeding could be trauma, oral surgery, tonsillectomy, infections, or could be spontaneous. If the bleed is in a closed space, it will cause pain, tissue damage, even airway obstruction in the case of head and neck injuries. Epistaxis, this I said is common. Hemophilia clinic gives instructions for controlled bleeding with local measures. If not successful, we always give factor and antifibrinolytics. Oral bleeding, same thing, you always want to do for the children who are just learning how to walk, the toddlers, and they keep on falling. So they always come with frenulum cuts. And these ones are normally hard to control. Sometimes we have to admit and even transfuse because they lose they become anemic due to the persistent bleeds. And we normally treat with antifibrinolytics. and factor concentrates. So the other causes of oral bleeding in children could be eruption and or exfoliation of teeth, tonsillectomy, those are procedures that are common, tooth extractions, tongue lacerations, frenulum tears. So thank you very much. I hope you have enjoyed our engagement, and on to the question and answer segment.
Thank you so much for our listeners. I hope you have listened and learned something. We go to our questions. First question is, so what factors is missing in the acquired hemophilia? Sister Nguche will answer that.
It could be any, that is factor 8 or factor 9, depending on the testing that we do. We do coagulation profile and then come down narrowing to the APTT. APTT will be so high or prolonged in both hemophiliacs A and B, but you have to come down to the correction, to the mixing studies that will give you the type of hemophilia, either A or B. It will narrow down to what type of hemophilia, but I bet tomorrow we are still having the diagnosis being presented. So I think you'll learn more tomorrow.
Okay, Pauline Mandembe has asked, can a hemophilic with severe disease get circumcised if it's a boy?
Yes, a hemophilic patient can get circumcised or go through any major surgery with the availability of factor. We have said during major procedures, the patient has to have 100% replacement before and after surgery. So when there are these replacement agents, you give 100% before the patient goes in for the circumcision or the major surgery, and after the surgery, then it can be scaled down.
Okay, George Manchama has asked, how do you make an exact diagnosis of hemophilia A and B? Is it necessary to, if it is A or B? I think tomorrow we are having another session and they'll talk about diagnosis of hemophilia. So George, don't miss tomorrow. The other question is, why does hemophilia affect men compared, I think it was to say compared to affecting women? Why does it affect men than women?
Okay, it is the women are the carriers of the gene. That is X chromosome, which is gotten from the mother. Or if it's the father, it is the X gene that is carried. It's carried by the father. So the men are affected because they get the X chromosome, the X gene from the mother. So it's the mother donates to the son. The father donates Y. So you find that the X, mostly it is a man's disease because the mother is donating the X that is affected.
Evelyn Chege has asked, have we mapped out where these patients are, apart from those seen in the KNH clinic? Are you working with the county blood banks to make sure we have enough cryptocryons or FFPs when there are planned elective procedures like circumcision? Countrywide uptake of Cryoprecipitate has been non-existent. They stopped preparing the component. Let's request the regional centers to be able to.
Okay, that will be handled tomorrow, but there is no specific region where we have the hemophilia disease. It is cutting across in the whole country, and you find that there is no specific place where we have more hemophilia patients. It is a given, the disease is cutting across the country.
And also to add on that, we're opening clinics all over the country so patients can access the hemophilia clinic everywhere they are.
And also, I think the first part of Evelyn asking about the cryo. We have said in your setting there is no cryo or FFPs, you give whole blood before you transfer. That is what has been happening in most places, in most parts of the country, and we give our numbers to this patient. So the patient, when the patient comes to your clinic, will tell you, please do this or let me go to KNH. So most of our patients have been helped in such a scenario.
Jeremiah Shem has asked, kindly explain about acquired hemophilia. Can the defective genes be transferred to a future sibling? Dr. Gidinji.
Thank you, Jeremiah, for that question. Acquired hemophilia, normally what we have seen is secondary to liver injury in patients who have other comorbidities. And so far, our experience and exposure to acquired hemophilia is not as diverse, but for the patient we currently have, we have not seen a transfer of genes, but we will be observing and probably give you feedback with future observations. Thank you.
Miriam Simiyu has asked, what happens in a couple of both hemophilia? What measures have you taken to avoid increasing people of hemophilia?
Okay, this is an interesting one. Just as I said, we will not desire to have such a scenario in our setting, but you never know, because we have these young men coming up and coming from the same setting, and they keep on intermingling. You'll find that there's a family that comes up with that. But we are doing a lot of family education, community education about hemophilia, and these families where there is an earmarking of hemophilia, we are always talking to them and telling them to know to map out their places where they are going. Let them map out their family so that they don't get themselves in such a scenario. I'm getting married, I'm a carrier getting married to a hemophilic, or I'm a hemophilic getting married to another hemophilic. But you never know, this can still come up, but there is a lot of health education going on. But in case there is this coming up, we only need to help educate the family and do a lot of family support and patient care and a lot of education, and yeah, that is what you need to do to the family.
Okay, Winnie Wanjiru is asking, in KNH, do you administer prophylactic factor replacement? If yes, which patients qualify for prophylactic factor replacement? Dr. Gidinji?
Yes, thank you so much, Winnie, for your question. Do we administer prophylactic factor replacement? We do not administer the factor concentrate themselves as factor 8, but we do have the Hemilibra monoclonal antibody. It's called Hemilibra or emicizumab. And we started with our pilot group of patients who had severe bleeds. So yes, that is the prophylaxis we offer. The other question is, what is the management of patients who develop factor inhibitors? Thank you for that question. It will be discussed tomorrow by our consultant, and I hope you join in and listen to how patients develop and how the inhibitors are managed. Thank you.
Okay. Helen Barongo Oino has asked, hello, can a hemophilia patient present with all the symptoms stated, or one presents with some or one of them?
Okay. Usually the patient can manifest in several ways. The patient can come in with either muscle bleeds, joint bleeds, or nose bleedings, but the patient can come in with one manifestation. But at times you find that the patient has both knee compartment syndrome coming up with bleeding in the urine. So we just take the patient and treat with 100% factor replacement, depending on the type of the bleed. But whichever way the patient presents, one bleed may lead to another. So the patient coming in with the muscle bleed can worsen because of low factor concentrate in the blood, and the patient can develop another one coming up at the same time.
Norbert Peshu has asked, are the clotting factors available in the county hospitals? And if not, what other available measures should one take?
Okay, the the factor concentrators are available in our county hospitals, where we have the clinics being opened. And in case there is a county hospital which does not have the clinic, hemophilia clinic, we earmark either a place in a casualty or a clinic, pediatric clinics, where we have our factor resident, but we always have our patients in those places. Usually when Kenyatta National Hospital receives all factor concentrators for the whole country and distributes to the county facilities that have been opened. Yeah, and the concentrates are free of charge. We only charge the services that we give, either nursing service or yeah, but the concentrates are free of charge. So most county hospitals give free factor replacements, all.
Okay, Winnie Wanjiru has asked, is there a role of DDAVP in management of hemophilia? Dr. Githinji had covered that. Jeremiah Shem, how do you manage a patient who developed DVT and PE and following factor concentrate administration?
Okay, maybe Shem, we do not have a concentration of we do not have DVTs or PEs in our clinic. We only deal with the hemophilia. But tomorrow you can come. It will still be covered in tomorrow's presentation.
Still, Shem is asking, do we have a non-gene therapy other than replacement for factors?
Okay, gene therapy is ongoing in other countries, but in Kenya it has not reached, but we are hoping very soon it will be done.
Yeah, one has asked, is it is common? Is it common to see a prescription of both factor 8 and 9 and tranexamic replacement?
Okay, I think that question is asking, is it common to see factor 8 or 9 prescription? That is to mean you've received a prescription that had both factor 9 and 8 and tranexamic acid. Is that in order? So usually what we do, if a patient has factor 8 deficiency and they have a bleed that is not contraindicatory to the use of an antifibrinolytic like tranexamic acid, yes, you can give a patient factor 8 and support the other days with tranexamic acid. But you cannot have factor 8 and factor 9 infused at the same time. So this patient, it means this patient has not been diagnosed and you need to refer them to a lab that will do the coagulation profile and diagnose the patient to either be factor 8 or factor 9. Thank you.
Marcos Jelly is asking us to repeat by showing the table summary for the factor replacement. Okay. Do you provide, George Mochama has said, do you provide treatment plans for each case?
Yes. Yes, we do treatment plan for every patient as the patient comes in. Yeah, with whichever bleed that the patient comes in, we do specialized patient care.
Gershom Abakalwa is asking, kindly indicate if our laboratories are able to determine the percentage of factor 8 or 9 to diagnose hemophilia.
Yes, most of our labs are doing the factor assays and diagnosis, and this is being supported by Novo Nordisk, even in the county facilities. So if you go to a county facility, this should be done.
Lydia Manze is asking, with the low prevalence of hemophilia, should genetic counseling and testing be included in premarital counseling?
Yes, it should be done, just in case you find a patient where you find the patient might not know that actually we don't have carrier testing. So in case of anything as an eventuality, it is good to give this information.
Somebody is asking, are IM injections contradicted in hemophilia patients?
Very much contraindicated. Just in case you prick this patient and the patient bleeds and you don't have any factor, it will be another story of the day.
Okay, Eunice Mbabu is asking, for patients requiring dental treatment, how far apart should the dental appointments considering the patient need for factor replacement before treatment?
All right, so for patients who need dental procedures, our patients are just like any other. They may need a dental visit, maybe for teeth extraction or a root canal. Our practice and the right practice is to first screen for the procedures that are needed. Is it a minor tooth extraction or is it a major procedure like a root canal? And so we always aim to replace factor percentage to at least 80 to 100% before the procedure, and you repeat the same after. Then you can also support the patient with antifibrinolytics for at least 3 days orally until the healing is achieved. Thank you.
Francois is asking, what is the cutoff for factor activity in mild hemophilia? Is it 25% or 40%?
The cutoff for mild is between 5 to 25%. Moderate is 1 to 5%, and severe is 0 to 1. So mild, the cutoff is 25%.
Still, Stella is asking, what is the type and dose of steroids in hemophilic with hematuria?
Okay, the type and dose of the steroid will depend on the type of the bleed. But if it's in hematuria, you also use the weight cutoffs to calculate the steroid amount to give. So mostly you have to know the weights of the patient in hemophilia management.
Somebody is asking, what could you advise on treatment of someone or male who nosebleeds oftenly?
Okay, a person who nosebleeds often it could be a leading of a disease called von Willebrand's, which is always mistaken to be, but it's a rare bleeding disorder. So you always tell the person to screen. If there is no hemophilia A, hemophilia B, the person might end up having von Willebrand's disease.
Joshua Wachilonga is asking, does postcoital bleeding occur in hemophilia?
It occurs during, especially in erection, in times of surgery or circumcision. These patients bleed a lot in. Okay, after that is postcoital, there could be a lot of bleeding because of the erections. Yeah.
Florence Kenya is asking, are the factor concentrates given as start doses?
So yes, factor concentrates can be given as start doses if those are minor bleeds that on clinical judgment, you can see that these patients' bleeding will resolve after just 1 dose. But there's also scenarios where we have repeated spread out doses of factor concentrates, depending on the severity of the bleed. For example, if someone has a compartment syndrome, 1 dose is not enough to achieve hemostasis and to rehabilitate that muscle compartment. So we do continuous infusions over a spread out.
Okay, somebody has asked if we have talked about management of inhibitors. Please, it's tomorrow. I'll urge you to be there tomorrow. Now that IM injections are contraindicated, how do they get drugs like tetanus vaccine and other IM vaccines?
Okay, most of our patients who are being vaccinated, those are mostly the children. What we do with the patients, for the patients who have never been exposed to IM injections, we always encourage them to come for factor first infusion, then they go for the IM injection. Just in case there is swelling after the administration that is not going down or it is reddened, we still give a factor concentrate. But with time, they wean off and they get their injections without factor replacements.
Our last question. I'm always experiencing nose, it's from Benjamin. I'm always experiencing nose bleeding every time I'm taking cold bath in the morning. What might be the cause? Dr. Gidinji?
Thank you, Benjamin, for that question. Probably you are a candidate for screening if it is a frequent and recurrent occurrence with the nose bleeding. So our advice is to come and screen, get a coagulation profile test done, and then we can assess you from there with the factor assays, and then we will manage you going forward. Thank you.
We only have one question left from Barbara Ayuki. Do we just ask for factor 8 or 9 on lab requests?
So when, as a clinician, you're requesting for screening for a possible bleeder, the best test to request for is a coagulation profile. So request for a coagulation profile, then ask for factor assays. So in the same test, it's coagulation profile with factor assays. So in the event that the patient has hemophilia, either A or B, they give you the percentages so that you can also diagnose the severity of this patient. Thank you so much.
Okay, thank you so much, our listeners. We have come to the end of our session. Tomorrow we are still having a session on hemophilia. Please do attend at the same time. Thank you so much.
Have a lovely afternoon.
Have a lovely afternoon.
Thank you.